Hi guys, my name's Sanjay Gupta. I'm a consultant cardiologist in York. Now, a lot of people contact me because they have symptoms that have led them to have investigations on their heart. And one of the commonest investigations that we as cardiologists offer patients is an echocardiogram or an ultrasound of the heart. Okay, and many people then get hold of their echocardiogram reports, which contain a lot of jargon and numbers, some of which can generate a considerable degree of anxiety because patients don't understand what it all means. And so I thought it would be a good idea to do a video where I could help you make sense of your echo report. Okay. So the first point to raise is, why do we do echoes and what information do they give us? And the answer is simple. An echocardiogram gives you insight into both the structure and the function of the heart. And we know that people who have a structurally and functionally normal heart muscle have a much better long-term prognosis than people who don't. Okay, so if your heart on your echocardiogram looks normal, in general, your prognosis is far better when it comes to heart disease than if you have a structurally or functionally abnormal heart. Okay. Um, what information does an echo not give you? It doesn't tell you anything about the blood supply to the heart. Okay, the heart is a muscle. Here is the heart. Let me just show you. This is my model here. Okay, so when you're looking at the heart on an echo, what you cannot see are these blood vessels which are providing the heart muscle with blood. Okay, you can see the heart itself like this, but you can't see these blood vessels. So you can see the heart, you can see inside the heart, but you can't see these tiny blood vessels which are responsible for supplying blood to the heart muscle. So an echo is not a good test to study the heart arteries or the blood supply to the heart. And the other thing that an echo doesn't tell you is it doesn't tell you anything about the electrics of the heart. To study the blood supply of the heart, you need to do something called an angiogram, which is where you inject dye in some way to directly visualize these arteries. Or you can work out indirectly whether these are okay by doing a stress test. Okay, and to study the electrics, you need to do an ECG at the time when the electrics are malfunctioning, and that'll give you the answer. But if you have a structurally normal heart on an echocardiogram, then even if you have heart artery problems or electrical problems, your prognosis is generally much, much better than if you had a weak or damaged heart. So an echo is a really useful test because simply anything that affects the heart in a bad way will affect the function of the heart. And if the function of the heart is good, then that's really reassuring news. The other thing to say is that an echo is particularly useful because it's one of the few things that allows you to study the function of the heart, you see. Most tests involve taking pictures of the heart, but the heart is a moving object, so how do you actually take pictures of a moving object without getting blur, etc.? But an echocardiogram actually allows you to study the heart when it's moving. So that's really powerful information. And that's why an echo is so important. Plus, it's very easily accessible. Virtually every hospital has it. You know, you don't need hugely trained, it's not too specialized. Most cardiologists understand echocardiography really well. An echo is not painful. It does not contain. It does not consist of having any needles put in or anything like that. It is simply an ultrasound, like pregnant women have when they have their wombs looked at before childbirth. So an echo is a very harmless test, but gives you lots of really good information. So now the thing is, well, how do we make sense of what the report contains? So if you have had an echo and if you've asked for your report, you'll see all this jargon that's been generated in the echo report. And often patients will go to their doctor and the doctor doesn't have enough time to explain it all to them. So I thought I'd try and do this video to be able to help you make sense of exactly what the echo shows. Now, because this is a very information heavy video, I'll divide it into two. So this week I'll try and talk about the left heart, which is this part of the heart, the left heart here, all right? And I'll talk you through all the different bits of information about the left heart. And on Wednesday, I'll do a video on the right heart. So if you combine the two videos, you'll get really good insight into what the echo tells you. Okay, so let's go through the information that the report will contain. Okay, when you have an echo, you will also at the same time have a single lead ECG done. Okay, and this allows us to tally mechanical activity with electrical activity. So usually the first thing you'll see on the echo report will be some mention of the heart rhythm and the rate on the ECG during the scan. So the report will say something like patient was in sinus rhythm, heart rate was 70 beats per minute. Okay, that's because every time you have a decent echocardiogram, you should have an ECG at the same time, because when you're trying to make measurements, you want to know whether the heart is contracting or relaxing. And although you can visualize it, you can't time it unless you time it with the ECG. So there will be some mention of your heart rate and heart rhythm at that time. And if the heart, if it says sinus rhythm, then that tells you that you have a normal heart rhythm, and the heart rate should usually be between 60 and 100 beats per minute. But even if it is a bit faster, don't worry if it says that the heart rate was 110 beats per minute. That's nothing to be worried about, because a lot of people are undoubtedly anxious when they go and have their heart scan, and that causes the heart rate to go up. So that, I think, shouldn't worry anyone. Okay. The next thing is, the first structure we would normally look at is this thing here. This is the left atrium, okay, this part here. So here is the left atrium, this small chamber, all right? This is a very important chamber because we have started realizing that the state of the left atrium gives us great insight into overall heart health. The majority of heart problems are not because the heart itself has an issue, but actually the blood vessels, these blood vessels, you know, because they get hardened with time, mean that the heart has to work harder to get the blood round. And so the left atrium is very unique because, well, you can see how muscular the heart is over here, but the left atrium is very thin-walled. So if the heart is under any kind of strain, the left atrium starts stretching, all right? And so we know that if you have normal-sized left atria, then generally it tells you your heart is healthy. What is normal-sized? Around about 4 centimeters across. So the echo report will have some measurement. Some places they measure the volume, but other places they just measure a dimension. And if the dimension is less than 4 centimeters, then that tells you that the left atrium is not enlarged. What does it mean if the left atrium is enlarged? Usually it means that the heart is having to work harder than it needs to. Another condition in which the left atrium is enlarged is atrial fibrillation. If a person has atrial fibrillation over a long period of time, that causes the heart to enlarge as well, the left atrium to enlarge. But generally, if the left atrium is enlarged, it tells you that the heart is having to work harder than it needs to. That may be because you have high blood pressure. It may be because you have a leaky heart valve. It may mean, you know, it just tells you that the heart is working harder than it needs to. Is it dangerous to have a big left atrium? No, it's not dangerous, but what it does mean is that you just need to work out why the heart is working harder and manage accordingly. So if someone comes to me and they say, well, look, I'm not sure whether I have blood pressure, it's borderline high. I look at the left atrium and I say, oh yeah, but the left atrium looks big. That tells me that the heart is working harder. So if there is any doubt about your blood pressure, I would rather err on the side of caution and start treating it aggressively rather than leaving it for 3-4 years, you know, just to see how it goes. All right. So that's the value of the left atrium. If your left atrium is normal size, then that's really reassuring for your long-term heart health. The next structure here is this thing here called the mitral valve. Okay, so the next thing that the echo report will contain is some comment on the mitral valve. Now, the valves have structure and they also have a description of their function. So this is the mitral valve here. Now, most normal valves will be described as being thin and mobile. Okay, so they look nice and thin, they are very mobile, they open and close really nicely. If the valve is described as being thickened or calcified or restricted, then it tells you that the valve is structurally abnormal. Either it has been subjected to wear and tear from old age, or it's been damaged due to an infection such as rheumatic fever or endocarditis or something like that. Functionally, however, even though structurally it may look abnormal, functionally it may be normal. It may still open fine without restricting blood flow. It may close fine without causing any leakage back into the left atrium. Now, if the valve is structurally abnormal, sometimes it can cause an obstruction to blood it doesn't cause complete obstruction, but it may impede some blood from getting through into the left ventricle here. In that case, where it's actually restricting blood from going through, this is described as stenosis, mitral stenosis. Mitral valve, and because it is obstructing blood flow, it's called stenosis. Okay, and that's usually something that happens with rheumatic fever. So because rheumatic fever is now becoming rarer and rarer, we don't see it that often. However, we do see a lot, these valves often do leak as well, okay, and we do see leaking of this valve a lot more. Now, there are lots of reasons why the valve may leak. The first thing to say is everyone's mitral valve leaks a tiny, tiny little bit anyway. And the reason it leaks a tiny little bit is because as we grow from childhood to adulthood, our chests flatten, and this alters the geometry of the valve, and that can cause a trace or a trivial amount of leaking of the blood. So a lot of people write to me and say, look, I've had an echo report and it says I have trivial mitral regurgitation, because leaking is described as regurgitation. They'll say, I have trivial mitral regurgitation, I'm really concerned. What does that mean? That is a normal thing, okay? Everyone has trivial mitral regurgitation. When you look at this, so the first thing is there will be some mention on whether you have any stenosis. If you don't, then that means that your valve is opening fine. Then there will be some comment on regurgitation, and that tells you whether there's any leaking. Everyone has a trace. If your report says trace of mitral regurgitation, forget about it. It's normal. Even if it says mild mitral regurgitation, forget about it, particularly if your valve leaflets are described as being structurally normal. They're not thickened, they're not calcified, they're not, abnormal looking. Forget about it. Some people have this thing called mitral valve prolapse. Now, what I mean by that is that the valve opens like this, okay, and should close like this. Opens like this, should close like this. But in some people, what happens is you can get something called mitral valve prolapse, where the valve opens like this and closes like this, all right? Now, when it closes like this causes a little bit of leakage here, all right? Now, this is not an uncommon finding, and the majority of them don't progress, particularly if the valve leaflets look completely normal. However, if the valve leaflets are abnormal, then it is important to keep it under review because the valve is structurally abnormal, and this can get worse with time, all right? Now, you can also get leakage even if your valve leaflets are normal, partly because they may be malaligned, as I've just mentioned with mitral valve prolapse, or partly because the valve is attached to the ventricle here, all right? So the valve is attached to the ventricle, and if this chamber is in some way enlarged, then that will pull the valve apart, and that can cause some leakage. So that's another reason the valve can leak. So there may well be a comment on your echo report saying trace of mitral regurgitation, normal finding, forget about it. Mild mitral regurgitation, forget about it. But if they say there's moderate mitral regurgitation or severe mitral regurgitation, then that's perhaps a little bit more important. And why is it important? And I'll tell you why this is important if you have moderate or severe leaking, okay? Mainly for two reasons. Number one, if you have a leaky mitral valve, for example, what will happen is a certain amount of blood will get pumped out from this chamber, and a certain amount of blood will go back into this chamber. So let's use an arbitrary figure. Let's say 100 mils of blood should go out of the heart, but actually if you have leakage and 20% leaks back. So instead of 100 going out, you get 80 going out and 20% leaks back in here. All right. So what happens then? The kidneys get 80 mils rather than 100 mils. So the kidneys are very sensitive. They think, oh, the body is dehydrated. We're going to absorb more water from the urine. We're going to try and restore that circulating volume. So they will restore that circulating volume by absorbing water from the urine. But the problem now is, now you've got 120 mils in your system because you were never short of 80. It was never 80 mils. It was always 100 mils, but it was just that 20 mils had gone back and only 80 mils had come out. Now you're left with 120 mils, right? And as time progresses, what happens is now you've got more leaking back because you've got more volume. So you've got more leaking back and more going forward, but still not as much as the kidneys expect. And so you get into this vicious cycle over a number of years where the kidneys absorb more and more and more, and the left ventricle starts filling up with more and more and more volume. And because the left ventricle starts filling, it starts stretching. And because it starts stretching, it eventually starts losing its elasticity. So usually what happens is the heart is a bit like a rubber band. You stretch it, it comes back together with force. You stretch it even more, it comes back together with even more force. But at a certain point in time, if you stretch it excessively, it will not come back and it will become flabby like a rubber band would. And so this is the problem with a leaky valve, that as time progresses, the valve gets leakier and leakier. The kidneys absorb more and more because they're getting less blood, because more blood is being leaked back, and therefore there is more volume, and therefore the heart starts stretching. So, and if the heart stretches beyond a certain point, then it can start weakening. And that's why it's so important to keep an eye on the valve if you see moderate or severe leakage. The second problem is that, of course, if you've got so much leaking back that blood can't come in from the lungs into the left atrium because the left atrium pressure is already high because all this blood's leaking back, then fluid can accumulate in your lungs and cause you to become very breathless. So it is important to keep an eye on the valve, because if the valve starts becoming so leaky that it causes you breathlessness, then it's important to operate on the valve and correct it either by replacing it or repairing it. And secondly, if there is any sign that the heart is beginning to stretch excessively, then it's worth fixing the valve, all right, through an operation. So that's what you'll find on the mitral valve. So there's some mention of the structure and some mention of the function, whether it's stenosed or whether it's regurgitant. Then the next chamber that we come to is the left ventricle. Now, this is the most important chamber of the heart because it is responsible for pumping blood all the way around the body. So it supplies the whole of the body with the blood. And patients who have a weak left ventricle have a much worse prognosis than patients who don't, okay? So the echo will firstly comment on the size of the left ventricle, okay? And it's really important because, as I say, if the ventricle looks bigger than normal, then you have to be worried that it's being stretched, either because you have a leaky valve or it's been damaged in some way. And the problem is, the more it stretches, the more likely it is to lose its stretchability in the long run, and therefore it can weaken. The general measurements are dependent on your body surface area. But in women, we would say no more than 55 millimeters or 5.5 centimeters if measured from at its widest point. So when the heart is relaxed, you don't expect it to be more than 5.5 centimeters in women and not more than 6 centimeters in men. And if it is bigger than that, then you just start thinking to yourself, well, why is it looking a bit bigger? Is it because it's under some sort of strain? Is it because you're dealing with a leaky valve? You have to try and explain that. So there'll be some mention of the dimensions, and usually the comment would be left ventricle is of normal dimensions, or left ventricle looks mildly enlarged. Mild enlargement wouldn't worry me, but moderate to severe enlargement would worry me, because I would say, well, why is the heart now beginning to stretch? Okay. As long as it's not dilated, you can feel very comfortable and reassured. The second thing that the echo report will mention is something called regional wall motion abnormality. Now, remember, the heart is a muscle, and this muscle is supplied by blood vessels, which you cannot see on the scan. But if one of these blood vessels is damaged or has been blocked as a result of a heart attack in the past or something like that, then that part of the heart muscle that's supplying will die, and that part of the heart muscle will not move on the scan, and therefore a specific region of the heart will not move, and this is called a regional wall motion abnormality, and points to a previous heart attack, or possibly sometimes even an infection of the heart muscle, which has caused an area of the heart not to move. And that's important, because that indicates a scar in that heart muscle, and that's something that needs to be investigated. So a lot of people come to me and they say, look, I'm completely normal, but my GP says my ECG is abnormal. They say I've had a heart attack, and I would normally scan the heart to look for a regional wall motion abnormality, and I would then turn around to a patient and say, well, actually, I don't see a regional wall motion abnormality, so I would disregard your ECG. I can't see any evidence of a scar, okay? The other thing to say is, a lot of people who have had heart attacks come to me and say, well, was it a big heart attack? Was it a small heart attack? And again, in that setting, I think it's really useful to scan the heart, because if you don't see a big regional wall motion abnormality, if you don't see any big areas which are not moving with the rest of the heart, then you say, well, actually, you haven't had a huge amount of damage. Whereas if you do, then that is obviously clearly a serious heart attack. Then there will be some mention of the function of the heart. Okay, and what do we mean by the function of the heart? How much blood does it pump out with each heartbeat? And this is usually described as the ejection fraction. Okay, the ejection fraction is a very crude indicator. It is generally usually just visually assessed. Someone looks at the echo, looks at the pictures and says, oh, I think it's 60%, or I think it's 40%. You can make a more accurate estimate by tracing the outline on the screen of the ventricle when it's at its widest point, when it's at its narrowest point, minusing one from the other, and using using the difference and multiplying that, making a percentage of the difference, and that'll give you the ejection fraction. So, that is one way of doing it, but that takes a little bit of time. In most places, most hospitals, someone just looks at it and they'll say, oh, I think it looks normal. If it looks like it's coming in, most people will say it looks normal, all right? So if, on the other hand, the heart's doing this, then you say, okay, actually, that looks really quite weak. You'd expect the heart to be doing that, all right? So the normal value for the ejection fraction is 60%, all right? That doesn't mean your heart is beating at 60% of its capacity. It doesn't. All it means is this is the figure that you get. 60% is the kind of ballpark figure for a normally functioning heart. If the heart isn't pumping out as much blood as you expect, then it is described as being impaired, and often you'd see a comment saying left ventricular impairment. Mild left ventricular impairment is if we think that the ejection fraction is not 60%, so 60% could be like this, and if it's going like this, then you could say, well, maybe that's about 45 to 55%, moderate is 35 to 45%, and severe is less than 35%, okay? Now, many people get very worried because they may have had 2 scans in a row, a year apart, and they say to me, well, look, last time it was described as my ejection fraction being 62%, and now it's described as having an ejection fraction of 58%. Does this mean it's gotten worse? And the answer is definitely not. It hasn't gotten worse. The reason is this is a very crude measure. A lot of people just do it by visual estimation. And if I took two separate people and got them to do the same, to look at the same scan, one person may say, oh, it looks like it's 55%. The other person may say it looks like 60%. So there is an inter-observer variability. But also, if I got the same person to look at the scan on two separate occasions in time, the same scan, there may be a difference there. So an intra-observer variability. And I would say the variability is between 5 and 10%. So if your heart scan is within 5 and 10%, I wouldn't be too worried about that. It could well fall within the normal kind of inter-observer, intra-observer variability. Okay. Then there will be some mention of the thickness of these walls here, the muscle walls here, all right? Why are these important? Because the heart is a muscle. If the heart is having to work harder, it will become more muscular, like with any muscle. If you look at my bicep, for example, the harder I work my bicep, the bigger it will become, the more muscular it will become. So with the heart as well, this is very similar to that. If the walls look more muscular, then that tells you the heart is working harder. Okay, these should be no more than 12 millimeters thick here and here. This is the septum, the wall in the middle between the left and the right. They should be no more than 12 millimeters thick. Okay, if they are thicker than if they are thicker than 12 millimeters, then this is described as hypertrophy, so left ventricular hypertrophy. Now when you see left ventricular hypertrophy, you have to ask yourself, why is the heart working harder? Why is it more muscular? Usually it's because of high blood pressure. If you suffer from high blood pressure, the walls of the heart muscle will look thicker. Okay, so either it's working harder, or the other option is that the heart muscle in some way is diseased, which is making it look thicker, and that is in things like hypertrophic cardiomyopathy. So many of you may know Sir David Frost, who used to present the Guinness Book of World Records, very famous presenter who died. And then after his death, his son, Miles Frost, unfortunately died. And he was found to have this condition called hypertrophic cardiomyopathy. And in hypertrophic cardiomyopathy, the muscle is actually abnormal because of a genetic problem. And this leads to the heart muscle being excessively thick. Okay, and the way you can tell the difference between the two sometimes is that when you have high blood pressure, all the heart muscle looks much thicker. So you get something called concentric left ventricular hypertrophy, i.e. the whole of the heart looks thicker. Whereas in hypertrophic cardiomyopathy or these kind of inherited problems, only part of the heart muscle looks much thicker, and it's described as asymmetrical left ventricular hypertrophy, which means that this wall here, the one in the middle, the septum, looks much thicker than this wall, and that gives us a clue. Having said that, you can still get concentric left ventricular hypertrophy in patients with cardiomyopathy. And then finally, there is the aortic valve in the left heart. Okay, so once the heart, the next structure to study is this valve here. This is the aortic valve. Note that it doesn't come very clearly in this picture, but if you look very clearly, yeah, there you go. You see it's got three cusps. And if in cross-section, it looks a little bit like a Mercedes-Benz sign. So when you look at it on the scan, it looks like a Mercedes-Benz sign. Okay, this is a very important valve because it allows the blood out of the heart to the rest of the body. And the valve, as I say, is made out of three leaflets. Okay, 1, 2, 3. And if you look at it in cross-section, it's got this circle, it's got these three lines between the cusps, and it looks like a Mercedes-Benz sign. And therefore, it is described as being trileaflet or tricuspid. Okay, the aortic valve can be described as being trileaflet or tricuspid, which is normal. Some people, in fact 1% of the population, have something called a bicuspid aortic valve, in which you have only two cusps. And the problem with a bicuspid aortic valve is that the normal hemodynamics, the passage of blood through the valve, is disrupted. It's not as streamlined because of this abnormality, and therefore this valve can start getting narrowed or leaky with time. So if you have a structurally abnormal valve, it's important that someone keeps an eye on it every so often after a few years, just to make sure it's not becoming leaky or narrowed. Um, and a small number do get worse. And if they get worse, then the big problem with this valve is, because it's actually allowing blood to the rest of the body, if it becomes excessively narrowed or leaky, then a lot less blood is going out of the body, and this can cause a reduced blood supply to the vital organs, which can then cause symptoms of breathlessness, chest pains, blackouts, and at that point it obviously needs correction. But if you have a tri-leaflet valve, then it's highly unlikely that this will be a problem in a young age group. But of course, because this valve sees so much, the pressures are high. As time progresses, many of them can actually narrow with time. So we do see a lot of people with narrowed aortic valves in old age. But generally, if we see it in young age groups, it's largely because they were born with either a bicuspid valve or sometimes something called a quadricuspid valve, where you have actually got 4 cusps. So if the valve is abnormal, if it's bicuspid or unicuspid or quadricuspid, then it's really important that someone just keeps an eye on this. But if it's described as tricuspid or tri-leaflet, then you can be reassured that your valve is structurally normal. Again, the valve will be described as being thin and mobile. And again, if it's described as being calcified or restricted or thickened, then it's important that someone just keeps an eye on it to prevent it from to ensure that it doesn't get worse. Unfortunately, there are no medications that stop it from getting worse, but it is important just to keep healthy and get regular exercise, because we know that those are good things regardless. All right. Again, the valve can, apart from being narrowed, it can also leak, and a trace of leakage we see, and that doesn't worry me. But if it is moderate or severe, I think it is important, because if it's moderate or severe, for the same reasons as this valve, the blood leaks back, less blood goes to the kidneys think you're dehydrated, they absorb more water to try and restore the volume of blood you have, and you can get into this vicious cycle where you're absorbing more, you're getting more volume, but more volume is leaking back. This causes the ventricle to get bigger and bigger, and it can lose its elasticity. And if it loses its elasticity, then you cannot be guaranteed that actually, if you repair the valve, that elasticity will come back. So that's the other thing. So those are the main things that will be commented on your echo report. The left atrium, the mitral valve, the left ventricle, and the aortic valve. Okay, and this is it for the left heart. This is the information that your echo report will have. I hope that you will find this useful if you have an echo, to make sense of the echo report. But in general, if your left atrium is normal, if your mitral valve is nice and thin and is not any more than mildly leaky, if your left ventricular walls are not more than 12 millimeters, and your left ventricular function is described as good, ejection fraction 60% or something like that, and your left ventricle doesn't look enlarged, and you have a normal tri-leaflet aortic valve, then that really tells you that your left heart is structurally normal. And if your left heart is structurally and functionally normal, your prognosis is very good. All right. So as this video contains quite a lot of heavy info, I'll do a video on the right heart on Wednesday. And I'd just like to finish by saying thank you so much for listening and watching my videos. I'm trying very hard to answer all your questions, and perhaps I'll try and start answering them in videos soon. My subscribership has dropped recently, and I would therefore really be very grateful for any support you can show my channel by sharing, liking, and commenting. It's soul destroying, when you wake up and you think, oh, my, subscribers have fallen by 100 to 200, and it's a horrible feeling, because this is one of the few things that really motivates me and keeps me enthused and keeps me energetic. So I'm very grateful for everything you do for me. I gain as much out of it as I hope I give you. So thank you so much. Many thanks. Have a great night. Bye.